So now it is my pleasure to introduce my colleague, my friend, my mentor, Dr. Millie Long. Dr. Long is an associate professor of medicine from the University of North Carolina. And again, everyone's bio is in your possession, but Dr. Long will discuss with us the diagnosis and management of extraintestinal manifestations of inflammatory bowel disease. Please keep the questions coming. And Dr. Long, welcome, and we're so happy you're here.
Thank you all, and thank you to Anita, and congratulations again on your IBD Center and obviously on Horizons. This is such a pleasure to be here. So let me get going. We have 10 minutes. This is quite a challenge. I do have the following disclaimers. And so where we'll go over the next 10 minutes is we'll first talk about extraintestinal manifestations associated with IBD, the types, whether they correlate with disease activity, and some of the treatments. We'll also talk about IBD extraintestinal manifestations associated with therapy. And what I mean by this is many of us are seeing more and more adverse effects that are cutaneous or extraintestinal when we're treating our patients with biologic and other agents. So we'll talk about these paradoxical complications of therapy, whether they be idiopathic, infectious, or malignant, and then also discuss treatment. And one of the things I'll do over the next few minutes is really focus on the skin manifestations and complications. I felt we had to dive into one area a little bit deeper. And so this is a case of this slide set actually missed a few slides. I'm not sure they loaded the right slide set, but this is a case of a young lady with underlying Crohn's disease who has a diverting colostomy. And she actually developed this very angry, painful, pus-covered lesion in the perineal area. And as you can see, it kind of has almost a violaceous border. And this is obviously pyoderma. So what are the extraintestinal manifestations of IBD? Which of these are associated with disease activity? And are there shared disease characteristics among these extraintestinal manifestations? So when we think about the prevalence of extraintestinal manifestations in Crohn's disease and ulcerative colitis, I'll show you here, Crohn's is the light blue and ulcerative colitis is the dark blue. We really do see more manifestations associated with Crohn's disease. And really, by far, the most prevalent is arthritis. But there obviously are also a variety, everything from aphthous stomatitis to erythema nodosum and down the road. But again, a little bit more with Crohn's disease. When we look by disease activity, as you can see here, the orange bars are active Crohn's disease. By far, active Crohn's disease, particularly for arthritis and oral ulcers, really seems to lead the way. But as you can see, even inactive Crohn's disease seems to be a little bit more prevalent than active ulcerative colitis. When you look, actually this was an older study, but when you look by disease location, and I bet you all have seen this in your practice, it really seems to be those with colonic inflammation that seem to have more of these extraintestinal manifestations. Colon only is visualized here in the dark blue. So regardless of the extraintestinal manifestation, the colonic involvement is an association. Certainly you can see it in any form of Crohn's disease, but that is a known association. So pyoderma begins with a sterile pustule or a papule or nodule, and it can rapidly break down to form one of these painful ulcers. And what really is characteristic about these lesions is the violaceous border. It's very sharply defined, and it kind of has this undermined border with a necrotic base. Location typically on the legs, but one area where I have seen a lot of pyoderma in my practice is peristomally, and this can be very difficult to manage. A lot of the topical agents we use for pyoderma can be very difficult with adherence of the appliance, and so we have to kind of come up with alternate treatment mechanisms for peristomal. And so this was probably one of the largest series of pyoderma. This was about 100 cases that were in a tertiary care referral center. And the median age varied widely, so anything from the 20s to the 80s. But we do see the majority of these cases were female. And that is a trend also for many extraintestinal manifestations. It seems to have a female predominance. Location, predominantly legs, but again, we see trunk, peristomal area as well. And in this series, the vast majority of patients had marked comorbidities. Inflammatory bowel disease was in 34% of these patients. When we think about the therapeutic options, most of the data in the literature are kind of at the level of case series. But certainly these lesions do seem to respond to steroids. I'll be interested to hear on the panel if my colleagues do this as well, but I do use a good bit of intralesional steroid injections and have found this to be very effective, particularly along the lateral margin of the border. We can talk a little bit more in depth about that, but that can be of benefit. Certainly immunomodulators, dapsone, cyclosporin, tacrolimus, topical tacrolimus on these lesions can be used as an adjunctive therapy. There have even been reports of thalidomide, hyperbaric oxygen in terms of wound healing. But perhaps the highest level of data is data with anti-TNF agents. This is the only randomized controlled trial data that we have for pyoderma, so I wanted to go over that with you. So this was infliximab in the treatment of pyoderma, and individuals were given either infliximab or placebo, and they assessed at week 2 for response of the pyoderma, and then a reassessment at week 6. And after that first assessment, individuals were given open-label infliximab. And there was a pretty dramatic difference associated with reduction in the size of the lesion, improvement, with 46% demonstrating that improvement on infliximab as compared to only 6% on placebo. But interestingly, I think this is a really important point, that the duration of the pyoderma really impacted the response. And so as you can see here, if the pyoderma duration was less than 12 weeks, they had a dramatic response to infliximab as compared to those with longer duration where it was not quite so evident. And so one of the important things about treating these lesions is treating them early when potentially it has more of a propensity to heal. However, when we think about some of the data in the literature that show very high response rates, we have to keep in mind that we really need interventional studies to help us to determine this. And I just wanted to use pyoderma as an example, where the response in interventional studies is about 20–25%, as I showed you. But in many of the series out there, retrospective cohorts, case series, it's almost 100%. So we really do have to recognize that difference. And that's true for the literature in terms of arthralgia and arthritis as well, that really interventional studies are needed in these extraintestinal manifestations to help us determine the true response rate, that it may not be as high as what's out there in the observational data. With that said, the only data we have on other mechanisms for pyoderma really are in the form of case series. So this was a recent publication of ustekinumab for neutrophilic dermatoses, and it was a series of patients who had failed a high number of prior agents. The majority of these were pyoderma, although it also included Sweet syndrome or amicrobial pustulosis, other neutrophilic dermatoses. And they did find remission in a vast majority of these cases, but again, no interventional trial data. So a second case in the last few minutes. This is similar to the case that Anita presented coming in. So this was a 27-year-old woman with a history of colonic Crohn's disease, and she presented with a new onset kind of itchy rash behind her ears and in her scalp. Her bowel movements were stable, and she was actually on adalimumab, 40 milligrams every other week for maintenance. In fact, she was in endoscopic remission from her Crohn's disease. And as you can see here, this is a picture of what was going on in her scalp. Clearly, this is a psoriatic eruption. In up to 10% of cases, it's really associated with other inflammatory conditions, as for my patient. And so we want to talk briefly about the cutaneous drug-induced extraintestinal manifestations. How do these commonly present, and what are the treatments? These are data surrounding various classes of medications. I think many of us are very familiar with thiopurines. Thiopurines can be associated with a hypersensitivity reaction, which can have cutaneous involvement, Sweet syndrome, infectious complications. Herpes zoster is increased associated with thiopurines. And in that instance, what we often do is treat with the antiviral. As long as it is limited, continue therapy. If it is obviously more disseminated, we do need to withdraw therapy. We have to remember that non-melanoma skin cancers are also an adverse event that is cutaneous, kind of induced by drug, and treatment, excision, patient education. One thing I do want to emphasize, particularly about the thiopurine-induced non-melanoma skin cancers, is that's driven by UVA light, potentially prevented. So we really do need to counsel our patients on sun protective clothing as well as sunscreen use. Methotrexate can be associated with cutaneous eruptions, whether that be a maculopapular rash, urticaria, certainly photosensitivity, some risk of non-melanoma skin cancer. With the anti-TNF, certainly we can have drug hypersensitivity and skin infection. We do need to be able to recognize drug-induced lupus, which can have cutaneous involvement, certainly also arthralgias associated with drug-induced lupus. And this psoriasis that I just showed you, it's estimated to occur in 3%, I would say anywhere from 3 to 10% of cases, more commonly in women. But importantly, drug withdrawal is not recommended. I'll show you some data, but the majority of these cases actually respond to initiating a topical therapy, potentially adding an immunomodulator, particularly when the drug that they're on has allowed for endoscopic remission from their underlying inflammatory bowel disease. Certainly, the JAK inhibitors also associated with a risk of zoster, as well as non-melanoma skin cancer. And so, when we think about these skin paradoxical reactions, kind of retrospective cohorts in the literature have had many of these range anywhere from 2% to 29%. The incidence is 5 per 100, so I would venture a guess that everyone in this room has seen some of these manifestations. Again, the location, typically flexural regions, genitalia, scalp, where my patient had this. It's really not limited to IBD. It occurs with other autoimmune-mediated condition, and it can occur as early as 1 month into treatment, but we really tend to see it more in maintenance. And frankly, in my practice, I tend to see it more in people who are in remission on their anti-TNF. But again, the level are the data of retrospective cohort. So if you want to think about what are the risk factors, smoking, having Crohn's disease, as I showed you, rather than ulcerative colitis, increased BMI, and female gender. What decreases the risk is being on an immunomodulator or ulcerative colitis. Importantly, there was that large retrospective cohort study that I just discussed really showed us that there's no association with anti-TNF drug levels. So we used to think, oh, maybe it's because we're running the drug levels too high. Well, that's not the case. The drug levels are not different between the groups, so we don't necessarily think that by reducing your dose of drug, you're going to improve these lesions. And so in this treatment series that I won't walk through, it'll be in your slides, really I want to emphasize that a second anti-TNF, anywhere from 25 to 50% of patients will recur, so it may not be in our best interest to switch to an alternate TNF. The majority are really managed with conservative treatment. The main indications for discontinuation are really that the patient couldn't tolerate it due to the location. The scalp is a terrible place, itching, pain. They can have associated arthralgias with this, and that can also be rate limiting. But I do want to emphasize that after stopping the TNF, really the majority, over half, do have resolution of symptoms over the following 3 months. But an IL-12/23 inhibitor, as Anita presented earlier, can have efficacy, and in some series up to 100%. So just to summarize, we've been through a whirlwind in the last 10 minutes, but case 1, she really had perianal pyoderma, and I really optimized her anti-TNF agent as well as methotrexate, and she responded quite well to intralesional steroid injections. I did assess the underlying bowel inflammatory activity, which actually was okay. Pyoderma is one of those ones that can arise independently, regardless of disease activity. Case 2, anti-TNF-induced psoriasis of the scalp, topical steroid, UV light, continue anti-TNF. You can actually add a methotrexate in this scenario as well, which has been beneficial. If not tolerable or responsive to this immunomodulator, you can consider change in ustekinumab. But again, up to 90% of patients will respond to those therapies, so I would encourage a trial of that first before changing medications. So summary, extraintestinal manifestations are common. Risk factors are women, colonic disease, and ongoing severity of inflammation. Management really includes those immunosuppressive therapies we have in our arsenal for treatment of inflammatory bowel disease and controlling underlying disease. Extraintestinal manifestations can also occur as a result of therapies. Recognition of important cutaneous complications, really recognize this psoriasiform eruption that we see, a drug-induced lupus reaction. Often treated locally or topically, but cessation of therapy may be required, particularly for the drug-induced lupus reaction. And depending on the type and severity of extraintestinal manifestation, you can potentially initiate an alternate class. Thank you.